Now, the next session will be by Dr. Sayan Basu on stem cells, hydrogel, and 3D printed corneas. He heads the research department and is the head of the Oculus Office department in LV Prasad Eye Institute.
Thank you so much, Prajakta. Good afternoon, everybody. Thank you for having me as a part of the subspecialty day. I think it's a wonderful initiative. Lovely to see all of you here in this but packed room, and it's wonderful to be back in the city that I grew up in. So I'm going to talk to you briefly about stem cells, hydrogels, and 3D printed corneas in the context of corneal regeneration. I have a couple of disclosures. There are a few patents that are out on the products that I'm going to describe, and a lot of this research is funded by different organizations, some from the government and some from philanthropic support. So one thing that we must understand at the beginning of this presentation is currently all of these things are very tightly regulated in India. So every new product that you want to use, particularly stem cells or any bioengineered products, are regulated as new drugs, and they have to follow all the regulations that you need to follow to get any new drug into the market. So the entire opportunity that we had earlier of doing academic research in this area is gone. It has to be developed just like any new drug, which makes it a little bit complex. There are, you also cannot make any claims until the time that these are approved as therapy. So this is the framework within which we are working right now. What this means is that it makes the process very long. So this is currently the pipeline of products that we have at LVPI that we are developing in this area. There are other products in retina and other areas that I'm not talking about. But as you can understand that even preclinical, before you go to clinical trials, you have to do a lot of work in the lab on setting up the GMP production protocols. And this is usually after you've done the proof of concept studies, etc. Then get the manufacturing license, then do the preclinical studies. So this pathway itself takes anywhere between 3 to 5 years. And after you have completed this, then you come to the clinical trials. And there again, you have to go from phase 0 to phase 1, 2, 3, 4. And so this is again, you're looking at anywhere between 5 to 10 years. So this is important to understand that, those of you who are looking to innovate in this area, please be prepared for the regulatory, considerations. And it's not very easy to get to where you want to get. The other piece of advice that I have for people who are working in this area is, other than understanding the regulations, is also, identify a problem that is specific to India and where, cell therapy or gene therapy can bridge a gap, and focus on solid science, collaborate, partner, and make sure that whatever you're developing, don't get excited only by the possibility of what it can do, but also make sure that it doesn't cause any harm, and try to find a solution that is not only effective, but also affordable and practical, because most of the people who suffer from these problems are not able to afford very costly therapy. So we are trying to develop a product that is not $1 million therapy, that is something that is affordable to most people who have this problem. So the problem that we have selected is corneal stromal opacification, which is the #1 cause of corneal blindness in India. This is very different from the West, where it is mostly endothelial disorders or keratoconus. In India, these are post-infectious or post-traumatic scars. And if you look at stromal regeneration, which is what we are trying to aim for, you can either approach this through, regenerating or using an approach which uses keratocytes, which are the cells that produce the extracellular matrix, or you can use a combination of this. So I'm going to tell you about all of these different approaches. It's also important that you have a way of assessing what you're trying to treat. So we have developed these in vivo metrics through which we can figure out if the treatment that we are using is working. Through clinical imaging modalities, and also how you define what you're trying to treat. So you have to understand that it is not correct to simplify a corneal opacity that is causing visual impairment or blindness simply as, how dense the scar is, because there are other elements to it. There is also irregularity, there's thinning. So a scar is not just an opacity, it is a combination of opacity, thinning, or flattening and irregularity. So just making the cornea clear again will not help the patient see. You have to address all of these components. And then for all the preclinical work that I showed, it's important to develop animal models as well. So keratocytes and mesenchymal cells for corneal regeneration is what we worked on first. Our initial plan was to use autologous cells from the patient, but this is again from regulatory considerations very difficult. So right now we use allogenic cells which are derived from cadaveric corneoscleral rims which we get from our eye bank. We also use alginate for preservation. This is important because it allows for room temperature preservation of these cells, which means that once these cells are available, we can transport them to any of you around the country without having to maintain a cold chain, which significantly brings down the cost of this therapy. We have a GMP facility in-house at LVPI where these cells are manufactured. And before getting to the clinical trials, we made sure that these cells were safe, that they were efficacious both as prophylactic and therapeutic when we applied it for corneal scars and other corneal pathologies. And we have just completed 2 approved clinical trials, both with unpreserved and preserved cells. And the framework of both these trials was similar. We were working with superficial corneal pathologies, and the 2 trials, each of them had 20 eyes of 20 patients with either scars or necrosis or burns. This is how we make our cells. They are, like I said, derived from the cadaveric corneoscleral rims. So these rims are obtained from the eye bank. You obtain the limbus from them, digest it, and then once you have digested the limbus, then you grow them out. Initially you get a mixed population of epithelial and mesenchymal cells, but eventually you can get a pure population of mesenchymal glue, which is applied on just get a week of antibiotics. So we use very objective outcome measures to look at this, and as you can see from these photographs, typically this is the response that we see in scars. On your left is a superficial scar, on your right is that scar significantly ameliorated after months of therapy. And we also see improvement in other parameters as well, and this is what we are doing right now. We have to follow these patients up for 2 years before we can initiate the multicentric trial, which I hope some of you who are interested can participate in. So we got very good results with our mesenchymal cells, and like I said, we are following these up for seeking approval for multicentric trials.
Thank you, sir. It does seem like magic. And,
It is magic.
So there's one question which was bothering me, like is there endothelium also there in neocornea, or it can be used for DALC?
You can theoretically put endothelium also. We are focusing on the treatment of scars, so we are, our focus has always been on stromal regeneration, and George is the right person to talk about endothelium. And if he can give us the endothelial cells, then we can definitely layer them on any substitute.
Yes.
We are working on an idea that you may not need endothelium. Full thickness corneal transplant, so that maybe in a year or 2 years maybe we'll have some animal study outcomes.
Thank you. So are there any questions?
Any question, comments, anyone from the audience?
Chalo, thank you so much, Projector.
Thank you, sir.
Thank you, Domo.
Our next speaker is none other than the inventor of SLET,